Right out of school, I went on a CEU binge. I was trying to do everything that I could to get better ASAP. Blood flow restriction, dry needling, manipulations, IA stem, cupping, you name it. I was speed running certs. But whenever I had a new eval, I still felt like I was guessing every single session. I was throwing the kitchen sink at every single patient, just hoping that one thing would just work out. And that hopefully I didn't make them worse by the time they came back around again. It wasn't until I developed a system that the game changed for me. I was able to go into every treatment, know what questions I was asking, what test I was running, what treatments I'm implementing, with confidence that not only the patient would feel better by the time they saw me again, even within that same session. In this video, I'm going to show you the 3 things that keep outpatient PTs stuck and how to fix all of them, and gain the confidence within themselves and their patients, and it had nothing to do with any extra certifications. Trap 1. The experience trap. This first trap is actually what society has fooled us on. The belief that time only in the clinic is what makes us better. Put in the reps, see enough patients, and that'll be enough to let the experience do the work. For 3 years, I could not figure out why I wasn't improving the way I expected, because here's what nobody's gonna tell you. There's a difference between a PT with 10 years of experience and a PT with 1 year of experience lived 10 times. I'm gonna give you an example of what this looks like in a real clinical setting too. I used to dread chronic pain patients. They're already exhausted by the time they see you. They've seen plenty of other MDs, saw all the specialists, got all the tests done, seen 2 or 3 other therapists. Now they're being referred back to therapy once again. So what would I do? See the patient, right? Do the eval, come up with the plan of care, see them for 6 to 12 visits. Then what? They didn't get any progress. And what does our profession tell us to do? This is even in our practice act, at least for where I'm from. If that patient doesn't show a positive, meaningful response within 30 days, that we should be referring them back out. But hey, that's what we did. That's what my mentors did. That's what my CIs did. That's what other therapists did in other settings I didn't even work in. As soon as patient's not showing any meaningful progress in a reasonable period of time, guess what? Gone. But if they've had this chronic pain for so long, what good are we gonna do about it? This is the common wisdom? Or is it just something that's been repeated over and over that we never questioned? There are plenty of examples of these common myths out there. In fact, one of the big ones in the past couple years has been of not letting your knees go past your toes while squatting. I've had to bite my tongue on so many different CIs in the past because of this too. I've had to learn how to squat before I even got into PT school, and I'm seeing all these trainers and therapists tell the patients not to let their knees go past their toes. It's just a load of bull hockey, passed along with no scrutiny. The worst thing is, why is everybody else so quick to give up on the patient when that patient hasn't even given up on themselves yet? And here we go again, repeating that same mistake over and over and over. We get so confident in that decision tree that we're no better than we were day one. All it really took to help this patient out is to really sit there and think about it. But from the inside, here we are getting more confident about these same mistakes that all our clinicians are making, and none of us knows about it because we're too trapped inside this box of what's been passed down without being challenged. Because real development takes intentional practice, reflection, and feedback. 10 years of entry-level practice is just 1 year repeated 10 times. So the next time you have a patient who's not responding, here's what we should be doing first. I want us to ask 2 questions. 1, have we asked the patient everything that we need to know about them, possibly rule out all root causes, not just the symptoms? And 2, have we made sure that we considered looking at the patient through the biopsychosocial lens, not just the old school kinesiopathic model? The goal of this is that we're trying to cover the gaps that we might have assumed have been covered to make sure we're not letting any stone be unturned regarding their diagnosis, their capacity, and their prognosis before we default to discharging them. And even then, I'm not going to give up on a patient as long as they're not giving up on themselves. And that's your first feedback loop to avoid the experience trap. And this is how your experience will actually compound over the years. Just remember, if you don't do this, you're not getting any better. You're just getting faster at the same mistakes. If this is the kind of thinking that you like to hear, because nobody's really teaching this, make sure that you like, subscribe, leave a comment, and make sure that you share with your other clinicians, as this is the stuff that really separates the cream to the top. Trap number 2. The information trap. So what happens when the driven clinician hits the ceiling of experience? Because we can only make time pass by so fast, right? We do the next logical thing. Go get more knowledge, more courses, more certifications, and everybody's favorite, more. This is actually my story at the beginning of this video. And listen, I'm not here to say CEUs are pointless. The knowledge is real and techniques do work. But just by learning new techniques doesn't mean that you're getting any better. It's just that your toolbox has expanded. The trap is there really wasn't a knowledge problem. Even by the time that we graduate and pass our board exam, we know enough information to be excellent. What we don't have is a framework to apply what we actually know. I'm a big proponent of actually understanding the evidence. However, that specific framework actually tells us what to do with the patient right in front of us. Without that foundation, all new information just gets thrown on top top of the pile that was never organized in the first place. This reminds me of that time that I described in the intro. I was freshly working, just hopped into outpatient care, was taking every certification that I needed to. My workplace was so focused on everybody taking the same CEUs so we could have continuity of care and standardized practice. That group of clinicians, there's probably 7 of us that were just PTs, and we all took the same dry needling course, and I'm not knocking it either because it became a big part of my practice. And of course, since we all worked together, we did share patients sometimes or similar presentations, and we all had that semi-standardized model. In fact, I made it such a point. I memorized every single thing that was supposed to be protocol because that's what was studied in the papers. So of course I'm going to do what was in the paper. I was getting pretty good results without even knowing the why behind it. Here's the real funny part. Patients, for some odd reason, gravitated on my schedule more times than not. Why are results so different even on the same patient? Aren't we all doing the same thing? A little odd. If all of us had the same knowledge from the same course and I was the least experienced in terms of years out of school, why was I getting such different results than everybody else? So no matter how much people want to focus on standardizing care, treatment will never and should never truly be that standardized across. And that's really because no course can ever replace the individual clinician's thinking. And the worst part is a lot of the courses don't ever go through how to actually build that. They just go through information dumps. And by the time we're at semi-standardized care across all clinicians within the same group with different results on the same patient, is it even semi-standardized anymore? How can we call it personalized care if we're trying to treat every patient with the same exact protocol? It doesn't make sense. More information does not close the reasoning gap. It just gives you more to guess with. So here's how you're going to overcome this knowledge trap. Before you try any new technique that you've learned, name the specific tissue and the reason why you're targeting it, based off of your hypothesis that you tested and funneled down through your objective exam that you already had a clue with because you did a damn good subjective. Not dry needling for shoulder pain because it helps, not something generic like a couple joint modes because you feel some restrictions. Explain it to me like I'm in front of you. Target the left levator scat because we observed increased tone, tissue, tightness, whatever you want to call it, on the left with decreased cervical rotation, an elevated scapula, a stuck towards downwards rotation on the same scapula. And we're also going to include specifically upper cervical modes, C1 and C2 because of the rotation differences, and we're going to work on the periscapular musculature, the ones that affect upwards rotation. Why? Because we're stuck towards downwards rotation, right? So whether you choose to do that manually or through exercise or through other soft tissue means, doesn't matter. You have to specifically pick it because you have a reason why you're doing it. This type of structure is going to be the foundation of your treatment. It turns every treatment you learn into a true clinical decision. Without it, every treatment that you do is just a guess. And with it, every treatment session is a new data point that you can either confirm or deny either works or did not work for you and that patient. I don't want you guys to stop chasing the knowledge, of course, but don't let the cart come before the horse. Have the foundation first, and no matter what you learn in the future, you'll be able to apply it correctly. We learned in school that evidence-based practice is a 3-legged stool. However, most people throw away the other 2 and beat every single patient up with that one leg. And if any other clinician disagrees, tries to beat them up with it too. Can't forget that clinical expertise and patient preferences are the other 2 legs. And in fact, I would probably argue that they were more important than the evidence side. Most of us do actually know a good bit of research just from school alone, or if you're aiming for passing a certification like the OCS. However, if you don't have a system, you're not developing clinical expertise. And the other major aspect is the patient values, which I'd argue the patient values should come first, then your clinical expertise, because that's what makes you you, and then the research, in my opinion. But if you agree with this line of thinking, then comment below, shift, and I'll send you the free guide that I made because most people are only practicing on one leg of the stool. Finally here, trap number 3, the credential trap. And trust me, I went through this one too, and yes, I paid for all of it, and yes, I completed all the work. But you guys can learn more about my story if you download the evidence-guided shift. Let's just talk about the example I see too often that's not me. The clinician that everybody works with and they work with for some time. That person has been in the field long enough that, they're feeling like an expert. They think they got this. They want to pass this test. Why? Maybe they think they'll get a raise. Maybe they just want to feel good about themselves. No shame in that, right? I did the same thing. That clinician has already failed for trap 1 and 2 already. So they take the test and they fail it. And now you just failed a $2,000 test. All right, but this clinician is really focused, right? They really want to pass this. They're dedicated to the game. They love it. They want to really push it. They want to get better for their patients, right? It's not their fault. Just remember that. It's not their fault. So what do? They study harder, and they study damn good. They learn every little bit of research they need to learn and how to pass the test. Well, guess what? Now they passed the test. Now here they are, board certified, OCS, whatever field you want to be in, right? They're just an evolved entry-level clinician that knows the research a little bit better than they did before. Still haven't developed their own thinking process, and they did the self-study route. So they were never mentored. That newly board certified specialist is now credentialed to mentor and pass down along what they know or don't know to an aspiring new residency candidate. And that new residency candidate that will hopefully pass their tests just fell for all three traps at the same time. The experience trap of the mentor above them, the knowledge trap of the OCS, and the credentialing trap number 3. That test is basically like the board exam, except on steroids, and about whatever specific subset that you're doing. It still did not tell you what to do with that information with the patient right in front of you. It just made you go and understand what the CPR, CPGs, and best practices are according to the published paper. The profession credentialed the one person who knew the research and called it the other, the person who's truly a specialist. And now that new specialist, still practicing at an entry level, is dressed up in new letters behind their name. The real trap, credential measures your test taking on what you know, not how you think. I want you to take the last clinical decision regarding a PT diagnosis that you were so confident in. And I want you to reframe what you ended up doing as their treatment and go back and find that whole chain of thought. How did you arrive at this? Not a newly researched protocol, not what your mentor told you. You cannot restate your line of thinking, then that line of thinking that you said that you did was borrowed from somebody else. I want you guys to be able to come up with your own decisions, even if we come up to the same conclusion, but get there by yourself, not because of me or anybody else that told you something. Borrowed reasoning makes you dependent on the next course, the next credential, or the next person telling you what to do. Owned reasoning compounds, borrowed reasoning expires. And that is the difference that separates the PT with 10 years of entry-level experience versus the PT with 1 year of experience practicing way beyond their years. Anyways, which of these 3 traps hits closest to home? I know I've lived through all of them. Drop it in the comments. I read every single one of them. And honestly, that helps me keep going, build more content for you guys, and drives my mission, raising the standard of care. I made a handout about the 3 traps we talked about in this video into a 1-page PDF that you can download. The 3 traps handout breaks down all the reflection prompts that we talked about today so that you can run this against your own practice immediately. Not someday, but right now after your next patient. There's not a lot of guarantees in this world. I can't guarantee the pace that you're going to improve, but what I can guarantee is that if you intentionally practice in this manner, that you will accelerate your clinical growth way faster than anybody around you who's not doing these things. Link is in the description, and remember that it's free. I'd recommend, just to ease yourself into this, have 1 reflection done per week for each column. And you're gonna have that intentful practice that you can grow from each time. And keep them. See how you grow over time or what cases really stick out to you. Because the more times you do this, the faster your pattern recognition becomes, and you're going to be able to filter and funnel your own system at that point. And I just have to ask again, if you got any value out of this video, please like and subscribe, share it with a colleague, give a comment below. Any type of interaction will drastically help the channel, and it's free for you, and it means a lot to me. Thank you, and I'll see you on the next one.